So, hope I'm audible and visible. If so, say me a hi, hello. Hey guys, can you hear me? Can you see me? I hope I'm audible and visible. Please let me know if you can hear me and see me. If so, let's start the class. Welcome everyone, and I hope that everyone must have been a little bit laid back after the NEET preparation. So this is a different exam, and hopefully your exam will not be postponed and it will happen as per the schedule. It will not get postponed, right? So welcome to all the PW NExT YouTube channel, and for the FMGE Spotlight, I am Dr. Ranjit. I'll be taking few important MCQs, PYQs related to pathology in the FMGE segment, fine? So first of all, can you guys comment on which part of the world you did your MBBS from, just to have an brief overview? Just give me a second. So if you've given your FMG exam before, I am sure you know the PYTs, right? So when I say PYTs, there are a few things which are important for any exam, from any exam point of view. The previous year topics, fine? Georgia, great, Anita. So for any exam point of view, the first and the most important thing is the previous year topic. So I'll give you an overview of what to do in the last 10 days available before FMG exam, what best you can do, right? So first thing, in the last 10 days, first solve all the PYTs or all the PYQs. You have the PYQs in the MedEd app. If you're not downloaded, use it, or any source. I'm okay with it. Good evening, Shisha. Any source, I'm okay with it. Please kindly solve the PYQs, because that, if at all any question repeats in the same way, you will not let it go, because making a mistake in PYQ is very difficult, and that's something is very basic for any person who's writing a competitive exam. The next thing, what do I do in the next 1 week in pathology? What are the high yielding topics which, if possible, I can read and revise so that I can score better in pathology? If you look at the FMG exams, the pathology blueprint over the period of years have slightly changed. Initially, it was predominantly one-liners, like most common cause of necrosis. This is the cause. The common cause of coagulative necrosis or liquefaction necrosis or cell death, right? It is very one-liner based. Now what's happened is, over the period of years, the entire exam has evolved to a scenario-based question. Does the concept change in that way? No, the concept remains the same. The only change is the asking the question has changed. Previously, the question was on caseous necrosis, answer is tuberculosis. Now the question is that 40-year-old person with history of fever, lymphadenopathy, cough with expectoration, and the microscopy shows caseating granulomas. What's your diagnosis? Ultimately, concepts don't change. So I want you to focus more on general pathology. I am not saying that don't focus on the rest. General pathology has good amount of questions in any FMG exams. Then it will be hematology. And in hemat, there are few basic things which I want you to remember. Not to go in depth about lymphomas. Definitely Hodgkin's is required. Few non-Hodgkin's lymphomas required for sure. Few or understanding of leukemia is also required. In RBC disorders, please don't leave IDA and megaloblastic. Next, hemolytic anemias. I am not putting hemolytic anemias first, but the only reason that majority of the questions in FMG exam till now has been asked predominantly on your iron deficiency anemia and your megaloblastic anemia. Hemolytic anemia also, yes, maybe the thalassemia, spherocytosis, the common ones, right? Not the rare ones, don't go behind them, right? And when you come to systemic pathology over the period of years, you can easily solve systemic pathology if you have a good, fair enough understanding of the patient. Let's say I'm dealing with a case of nephritic syndrome. Dr. Santosh must have talked about nephritic syndrome for sure, right? So you can take inputs from that. If I'm having a question on minimal chain disease, you can take inputs from pediatrics. Dr. Sarasar must have talked about that, right? If I take about a surgical cancer, like colonic cancer or gastric cancer, you can take inputs from your surgery. Systemic pathology questions are almost always integrated. So there are few places where systemic pathology is required. I have few PYQs on systemic pathology also. We'll definitely go through them and learn around the topic some important pointers. But the main goal here is to learn and revise general pathology in the coming 10 days. An overview of your anemias and overview of leukemias, lymphomas, and systemic pathology. Most of the questions try to solve with the patient, because that's much easier than solving with a microscopy, because microscopy felt, right, the image whatever you read at the end of the day, it becomes very difficult to remember, right? So without any delay, let's go on to the questions. I want you guys to comment on the answers. I'll leave the question blank, thing blank for next couple of seconds. So read the question, I hope it's visible, and then comment on the answer. I'll go message mute for the next few minutes, maybe half a minute. whoever is online, I want you guys to comment. It's fine if you make a mistake. The goal here is not to write the correct answer, to learn. Shesha, if you're online, Anjita, if you're online, the answer. Okay, Shesha has gone with A. Anyone else who wants to add on to it? Let's read through the question and let's see if the right answer is A or not, right? So this is a question on systemic pathology, right? So how do I solve this question? So let's go with one by one information given here. It's a 12-year-old child, okay, with cola-colored urine. So this disease is a nephritic syndrome or a nephrotic syndrome? The pure case of a nephritic syndrome, right? If it's hematuria, you are going to deal with a nephritic syndrome for sure, right? So if you look at these four options, which you can rule out. See, I'm going with the given information and trying to rule out the option so that it becomes much easier for you. Had mild proteinuria and hematuria, okay, it's possible in the your M gene is also a nephrotic pathology. I'll remove it. Is it seen? Can you guys see me? I hope I can see me and hear me, right? These both are nephrotic etiology, so easily I can rule them out, okay? Because I have a classical hematuria, I have a classical cola-colored urine, so the only two possibilities, PSGN and IgA nephropathy. And the mother says there was an episode of sore throat 2 weeks back. It's a very classical history. For every exam going aspirant, just don't jump to a diagnosis of PSGN just by looking at young age, URA and cola-colored urine. You might end up in might make a mistake, right? Because I'll tell you a very important finding here. This is very important. Yes, Daksha, you're right, it's PSGN. I'll give you two possibilities. I'm having an history of URA. There's a question having urinary tract, your upper respiratory tract infection. It's there, right? Post upper respiratory tract infection, there's a possibility after 2 weeks there is hematuria. Okay, that's the first possibility. I'm having 2 weeks after that hematuria. Second possibility, the second day of a URA, you're having hematuria. Tell me what will be the diagnosis of the second possibility. There's a history of URA. Second day after URA, the patient is presenting with cola-colored urine or hematuria. What is your diagnosis? Is it PSG or is it something else? Because this is the learning point here. Because if you know this, you will not make mistake in anything. Perfect, Shisha. It is Buerger's disease or a IgA nephropathy. Please do remember, the history is very, very important here. Buerger's disease, other name like Shisha said, the other name for Buerger's disease is IgA nephropathy. If you don't have a lag time immediately after URA or in UTA or in diarrhea, you end up in having hematuria and nephritic syndrome, I think of a Buerger's disease. But if there is a lag time, that's the most important clue in this question. It's not about hematuria and URA, it's about the lag time. They have 2 weeks. 2 weeks back there was an URA, so undoubtedly it could be PSGN, or I'm sure you know the other name for PSGN, which is PIGN, right? Post-infectious glomerulonephritis, right? So that's a basic difference here. Please look at the history. History is very, very important for any question in systemic pathology. You can even make a mistake just based on the lag time, right? If you have any doubt in PSGN, do let me know. If not, I'm going to go to a very, very important concept again in the next slide. So here, this is a classical urine microscopy, right? The urine microscopic finding. Can anyone tell me what are these? There are multiple things there in the urine microscopy. Can anyone answer it? Can anyone answer what they are? What you're seeing in the microscopy of urine? These are perfect. These are classical RBCs. Amazing, right? This is an RBC, right? So now I'm saying this how a hematuria microscopy will look like. So when I take or talk about a history of hematuria, am I right in saying that you can have hematuria and UTA? Yes. You can have hematuria and bladder stones, calculi. You can have, right? So in hematuria there are multiple causes of hematuria. So what in microscopy will tell me the hematuria is from glomerulus and not from the peripheral urethra, because urethra also can cause hematuria, right? UTA also can cause hematuria, right? So that's the diagnosis here. Now this is nothing but an RBC, like I said. If I zoom this RBC, tell me this particular RBC, whatever I am drawing here, they are smooth or they are looking abnormal morphology? Are they like a normal RBC or an abnormal morphology? Perfect, Shisha. They are abnormal, right? So abnormal means Dis means abnormal. So these are dysmorphic RBCs. Please keep in mind, if you see any question which says that dysmorphic RBCs in urine, the source of bleeding is glomerulus. The concept is very simple. If the bleeding has to happen in the glomerulus, the RBCs shed from the glomerulus go through the entire proximal distal convoluted tubule, collecting duct, ureter, your bladder, urethra, and then comes outside. So it's a very long journey of the RBCs. So in that journey, it obviously can get damaged, right? So if you see any question with dysmorphic RBCs urine, your diagnosis is glomerulonephritis and not UTI, because UTI can also cause hematuria. This can also cause hematuria, right? Again, one more important concept with respect to same hematuria only, right? I'll add on to this. See, let's assume you have a patient with hematuria, right? I want everyone who's online to answer this. It's a very interesting concept. This also came once in a PYQ in your FMGE exam. Patients have hematuria, but there are no RBCs in urine. Okay? The patient is having hematuria. Hematuria is a symptom, right? It's a patient or a cola-colored urine, but there are no RBCs in urine. What will you think of? There is no carrot or beetroot intake. There is no drug intake, which is causing an altered color, right? No hematuria clinically, but no RBCs in microscopy. What's your diagnosis? It's a very important concept. This has come before in an exam as well. Great transverse fascia. Porphyria is a very good differential diagnosis. Let's assume porphyria is not the possibility here. Is there anything apart from porphyria? Anything apart from porphyria? If you have a patient with hematuria and no RBCs in microscopy, even in a real life or in an MCQ, I want you to think of an hemoglobinuria. Hemoglobinuria also causes red color urine, right? This means my diagnosis is some of an hemolytic anemia. Okay? The reason why I'm not taking porphyria, transverse fascia is hemolytic anemia is any day much more common than porphyria, right? You have an autoimmune hemolytic anemia, your thalassemia, your sickle cell anemia, right? They are much more common than porphyrias, right? So any intravascular hemolysis will result in hemoglobinuria. Keep in mind, it will be red color to the naked eye, but in microscopy I'm having hemoglobin and not RBCs, so there will be no RBC in urine, right? So diagnosis is totally different organ system. Your diagnosis, our answer is going to be totally different, fine? Just since we are in glomerulonephritis, I'll add few more pointers. I want you guys to just comment on the answer. Just we'll quickly revise glomerulonephritis. Okay. Obviously, the most common cause, though it's not very important, I just want to cover them as well. The most common cause of nephrotic syndrome in a child. Hope I'm audible. So, fine. So the classical features of nephrotic syndrome were massive selective proteinuria, lipiduria, hyperlipidemia, and loss of antithrombin 3. I think the audio was not clear initially in between. Okay. Sorry, Daksh. I hope you can listen to me and hear me as well now. Fine. So these are few classical features of nephrotic syndrome pathology. Fine. So that was about the first questions. We'll just go quickly to the second question. This is a simple one-liner. There are just few added point towards this one-liner. I'll add to that. That's all. Fine. So can you guys comment on the right answer? Who is online? Good evening, Ranjit. Hope you're doing good. Which of the following disease will result due to a defect in dystrophin? It's a very simple one-liner. and it's there. You must have definitely heard about the disease as well. Can you guys comment on the answer? The answer is perfect. Listen, Duchenne's muscular dystrophy. See, muscular dystrophy is a very, very vast topic. Again, it's not something which is very important from an undergraduate point of view, at least from pathology. Maybe medicine of neurology might be required to learn more, but limb girdle muscular dystrophy, Emery-Dufresne muscular dystrophy, central core disease, all these you not read much in depth. The basic two muscular dystrophies which I want you to know, one is Duchenne's muscular dystrophy, that's DMD, which is a total absence of dystrophin. Okay, there are a few questions just come with respect to Duchenne's muscular dystrophy. I'm just going to cover them. And also there's one more disease called Becker's muscular dystrophy, right? What do you think will happen in Becker's muscular dystrophy? As if you're online, can I say it will be absent dystrophin or reduced dystrophin? It's perfect, it is reduced dystrophin, right? One is Duchenne's muscular dystrophy, the other one is Becker's muscular dystrophy. So one will be an absence of dystrophin, the other will be a reduced amount of dystrophin, fine. So there are, like I said, there are few classical one-liners which comes in Duchenne's muscular dystrophy. Because of the absence of dystrophin, the muscle cannot function. If a muscle is not functioning, what do you think will happen to the muscle? Will the muscle stay back or the muscle will be atrophied? It will definitely be atrophied, right? So because of this absence or reduced dystrophin, you will have abundant muscle atrophy. The entire part of the body, the muscle becomes atrophied. So when the muscle becomes atrophied, especially in the lower limbs, you will not be able to sit down and stand up properly. Because of this muscle atrophy, there's a classical clinical sign called as Gover's sign. I am sure you must have seen patients. If you have not seen patients, you must have definitely learnt about Gover's sign. It's climbing on oneself. You sit down for half an hour and you wake up, you stand up, we will climb on ourselves, right? That's Gover's sign because of the weakness of the lower limb muscles, right? The same thing happens in Duchenne's muscular dystrophy as a part of pathogenesis. Again, because of muscle atrophy, since the muscle is going to get atrophied, the lost muscle will be replaced by fat. This fat will replace the muscle, but fat is unfortunately bulky, right? So it looks like a classical finding called pseudo calf hypertrophy. It's actually not a calf hypertrophy. The muscle is lost and is replaced by fat. When it's replaced by fat, obviously the fat is a little bit more bulky than the muscle, so it looks like a hypertrophied muscle as a pseudo calf hypertrophy, a classical finding of Duchenne's muscular dystrophy, right? I just want to add one more finding before you go on to the next classical question. Duchenne's muscular dystrophy, can anyone tell me what will be the investigation of choice? I'll give you options, you let me know. Doing a muscle biopsy, is that the investigation of choice? Or going with genetic diagnosis? Or going with a clinical diagnosis? What do you think is the investigation of choice for Duchenne's muscular dystrophy or an electromyography? What do you think is the best investigation? Because this again came once in a very old PYQ in an FMGE exam only. The investigation of choice is genetic diagnosis. It's genetic diagnosis. Muscle biopsy is not done until my genetic diagnosis is negative. Because already the muscle is having problems, right? If I go and poke the muscle again, you'll have more damage. That's why muscle biopsy is not done. It's predominantly a genetic diagnosis. That's how you diagnose Duchenne's muscular dystrophy, right? Great. Let's go to the next question. I want you guys to comment on the answer. 100% sure that you know the answer. Let's get out of the cocoon. You right or wrong answer here so that you don't make the mistake in the main exam. Which of the following are true regarding, or which of the following is seen in patient with mother fetus RH incompatibility? What type of hypersensitivity is the question? Immediate, antibody mediated, immune complex mediated, or delayed hypersensitivity? Can you guys comment on the answer? Rajashri, Daksh, Vishar, transverse fascia, if you're there. The diagnosis is very simple. It's a classical case of an antibody mediated or a type 2 hypersensitivity. If you look at these four options, there are four types of hypersensitivity, right? This is the other name for type 1 hypersensitivity, immediate hypersensitive reaction. This is the other name for antibody mediated, is the other name for type 2 hypersensitivity. Immune complex mediated is the other name for type 3 hypersensitivity, and delayed is the other name for type 4 hypersensitivity. In addition to type 4 delayed, I have one more thing, it's also cell mediated. Okay, because it is T cell mediated, cell mediated hypersensitive reaction or a delayed hypersensitive reaction, right? There are four different types of hypersensitivity and these are the things. Hypersensitive reaction is a very, very favorite topic for FMGE exams. I'll just give you a few examples which has been previously asked so that you don't miss the wrong answer, fine? Okay, so immediate hypersensitivity or type 1 hypersensitivity, I need not give you examples. Everyone will jump into saying allergy is one of the important thing. Asthma, anything allergic, asthma or anaphylactic shock kind of thing, you will think of a type 1 hypersensitivity, right? That's very simple. Can you, any one of you comment here, what are examples for type 2 hypersensitivity? Whatever comes to your mind. Again, it's not about right or wrong. Whatever comes to your mind regarding type 2 hypersensitivity, comment. Like I said, type 2 is antibody mediated, right? So every autoimmune hemolytic anemia is type 2 hypersensitivity. ITP, what's the full form for ITP? It's immune thrombocytopenic purpura, right? That also is a type 2 hypersensitivity, right? Your Goodpasture syndrome, I have antibody, it's type 2 hypersensitivity. Your rheumatic fever is type 2 hypersensitivity, right? So type 2 hypersensitivity is a very big list. Every hemolytic anemias, I'm reading hemolytic anemia, AI, autoimmune hemolytic anemia, ITP is type 2 hypersensitivity, Goodpasture syndrome is type 2 hypersensitivity, while you have antibodies against collagen, right? You have, like I said, you have rheumatic fever. See, very important, please remember this, a rheumatic fever, that's your heart problem after streptococcus, right? It's type 2 hypersensitivity, not your rheumatoid arthritis. Rheumatoid arthritis is your type 4 hypersensitivity, so please be very, very careful, right? Great, Daksh, it's not a problem. If you have an Rh positive blood group, it's completely fine. So type 3 hypersensitivity, your circulating immune complex, SLE is a prototype, right? SLE is a prototype for type 3 hypersensitivity. Can anyone give me any one more example for type 3? Reactive arthritis is type 3, right? I'll tell you the reason why I'm specifying on this, because when I say rheumatoid arthritis, it's different from reactive arthritis. Reactive arthritis is type 3 hypersensitivity. At the same time, PSGN is type 3 hypersensitivity. Streptococcal heart disease, rheumatic fever is type 2. Streptococcal kidney disease, it is type 3. Reactive arthritis is type 3 and your rheumatoid arthritis is type 4. Okay, rheumatoid arthritis is type 4, remember this. And there are a few more classical examples for type 4 hypersensitivity, but at least I want you to remember type 1 diabetes mellitus, because there are a few sources which says that type 1 diabetes mellitus is type 2 hypersensitivity, which is wrong, right? It's type 4 hypersensitivity. Anything cell mediated, anything which will involve CD4 or involve granulomas or CD8 will be type 4 hypersensitivity, right? So this is a very classical example. These are important. Please don't go into an exam hall without knowing hypersensitive reactions. It's a very good topic for you to revise the day before the exam. There's definitely a chance that you might get a question from this. Fine. Okay. Now let's go to the next question. Okay. Again, it's a very classical question. Let's see how many of you guys give the right answer. Tell me again, whatever comes to your mind, you can answer. Nodular glomerulosclerosis seen in which of the following condition? Nodular glomerulosclerosis, I'm sure you know the answer. The other name for nodular glomerulosclerosis, I'll use the other name as well. It's also called as a Clemenstein-Wilson's disease or KW lesion. Tell me, where do you see KW lesion or nodular glomerulosclerosis? Nodular glomerulosclerosis is seen in patients with diabetes mellitus. It's a spotter in microscopy. You have to remember that this is the most specific lesion in diabetic nephropathy. It's a kidney finding, right? It's the most specific lesion of diabetic nephropathy. It's not the common lesion, it's not the earliest lesion. So if you have a question saying which is the earliest finding of diabetic nephropathy, the answer is thick GBM. Okay, thick glomerular basement membrane or thick capillary wall is the earliest finding, and the most common finding is going to be sclerosis. Sclerosis is the most common finding in light microscopy for a diabetic nephropathy, and KW lesion or a nodular glomerulosclerosis is the most specific finding for diabetes. Please do remember them. Again, since we are in the topics of glomerular sclerosis, we'll go with hypertension also. In hypertension, there are two types of microscopic finding which I want you to remember, because there are two types of hypertension. We have something called as benign hypertension, where your BP is in the range of 140, 150, and you have something called as malignant hypertension. The BP is in the range of very, very high BP, 190, 200 millimeter of mercury, right? So here I have something called as great. I have hyaline arteriolosclerosis, right? I have hyaline arteriolosclerosis. That is a classical finding for your benign hypertension, and here we'll have hyperplastic arteriolosclerosis, Okay, or the other name for hyperplastic arteriosclerosis most of you must have known as onion skin lesions, right? So onion skinning of the capillaries or the arterioles or the blood vessel is a classical finding seen in malignant hypertension, and a hyaline deposit is classically seen in case of benign hypertension. Fine. Like I said, it's a spotter, your nodular glomerulosclerosis. This is how a nodular glomerulosclerosis looks like. There's a completely normal glomeruli here, entire glomeruli, and I'm sure you can see a pink nodule here, a pink deposit here. That's your KW lesion. Please do remember, KW lesion is a classical finding in the case of diabetes. Don't forget this. Again, whatever we are going to discuss here are hand-picked PYQs which came in the previous exam. There are very high chances at least some of the questions from this discussion might get repeated in your upcoming exam as well. Fine. Let's go to the next one without any delay. This is not exactly a pathology question. I'm just adding it because I wanted to discuss something related to copper metabolism. That's why I discussed. Come to the right answer. 𝐿𝐻𝐿𝐻 had disease due to defect in which of the following? Quite a few of you guys are online. Do comment on the right answer. What's the right answer here? Okay, Monica has gone with copper. Anyone else wants to add on to it? 𝐿𝐻𝐿𝐻 had disease is due to defect in? It's absolutely right. It's copper, right? It's copper deficiency. So in copper, there are two concerns in copper, right? So copper, for it to get absorbed, there are two transporters required for me. One is ATP7A, other one is ATP7B. The two molecular transporters required for me for absorption of copper, right? So this helps in absorption of copper. This helps in 7B helps in binding of copper to your cellular plasmin. That's where it happens, right? So here in 𝐿𝐻𝐿𝐻 had disease, and the other one, like Daksh said, Wilson's disease, fine. In 𝐿𝐻𝐿𝐻 had disease, ATP7A will be defective, so there will be completely reduced absorption of copper. So when copper is not at all absorbed from the gut, obviously there will be copper deficiency, right? And like Daksh Puri said, in Wilson's there will be copper excess. Because in Wilson's ATP7B is mutated, right? This is what is mutated in Wilson's. So in Wilson's the problem is copper binding with ceruloplasmin. Ceruloplasmin is a transport protein of copper. That will be defective. So the copper will be absorbed, but the copper cannot bind to the transport protein, cannot go through the body, and it keeps on accumulating in the liver and in the blood secondarily, right? So that's the difference between copper. ATP7B is more important for an MCQ point of view. 7A is a copper deficiency, 𝐿𝐻𝐿𝐻 heart disease, right? And it's a classical finding of 𝐿𝐻𝐿𝐻 heart disease, very sparse hair. 𝐿𝐻𝐿𝐻 heart disease can also have hemolytic anemia. As copper is important for the maintenance of the integrity of the RBCs, that also will be lost. They have very sparse hair and hemolytic anemia with copper deficiency, diagnosis of 𝐿𝐻𝐿𝐻 heart disease. One more extra information I want to add here. In Wilson's disease, tell me what's the best investigating test. Again, I'll give you options. You choose just from the options. Is it ceruloplasmin levels in the serum? That's the best test. Or do you think the best test would be urinary copper levels? What do you think is the best one? What do you think will be the best one? Ceruloplasmin levels in the serum or urinary copper levels? Perfect. It is urinary copper levels is the best one. It's not ceruloplasmin serum, right? Most of them think that it's ceruloplasmin. Great, Monica. It's urinary copper levels is the best test for Wilson's disease. Yes, ceruloplasmin will be reduced, not a problem, but urinary copper level is definitely far more superior than ceruloplasmin. Because I'll tell you the reason also so that you don't forget it. Ceruloplasmin is formed in the liver. So ceruloplasmin is formed in the liver. Is there a possibility if there is a liver failure, ceruloplasmin will be affected? Hepatitis destroys liver. Will I have a problem in ceruloplasmin production? I'll have. But urinary copper levels will not alter except in Wilson's disease. That's the reason urinary copper levels is much more diagnostic of Wilson's than your ceruloplasmin levels, right? Okay, let's go to the next question. Read through the question and comment on the right answer, right? Okay, Daksh has jumped to the diagnosis. Daksh has gone with silicosis. Okay, it's 40-year-old person, glass grinding factory, history of corpus sputum production, and also he had pulmonary tuberculosis. Which of the following must have predisposed to this condition? Diagnosis? Okay, anyone else wants to add to Daksh's answer? Is it silicosis or is it something else? What is it? Answer? Perfect, right? It's a classical condition of silicosis. Now, there are few pointers which I want you to remember regarding any of the occupational lung disease, right? If you look at any occupational lung disease, there are few pointers for you. For which one, Avinash, anti-DNase is positive? Can you tell me? Is it for the PSGN? Yes, it will be positive for sure, Avinash, right? So if you think of a coal workers pneumoconiosis, I want you to remember a few things. Okay, the most common subtype of coal workers your coal workers pneumoconiosis is anthracosis. Anthracosis is the most common thing, but anthracosis is not occupational. Coal workers pneumoconiosis, there is no increase in risk of lung cancer. This is very, very important. Please do remember that. They can cause lung failure, respiratory failure, but they don't cause lung cancer, fine. Silicosis, again, coal, the working environment is coal mining industry. That's a very clear-cut one, right? So in this question, to come to a diagnosis of silicosis, the first thing is this: glass manufacturing, silica, cement, or the motherboards, or your watches, any of this manufacturing, silica is a very important thing, right? So for silicosis, the pointers which I want you to remember for silicosis is first, glass manufacturing, right? Or your cement industry, or your like I said, your motherboard or any hardware manufacturing, silica is important. This is the most common occupational lung disease throughout the world. Throughout your silicosis, asbestosis, coal workers pneumoconiosis is the most common occupational lung disease throughout the world. Silica has again few more findings. Great, like whatever Daksh said, I will have upper lobe involvement. That's an important pointer. In addition to that, there's a classical finding in hilar lymph node. Can anyone comment on the finding of silicosis in hilar lymph node? An X-ray finding is there in silicosis in hilar lymph node. What is that? X-ray finding? Great. You'll have something called an eggshell calcification. Okay. Eggshell calcification is a classical finding seen in silicosis, and silicosis or the silica particles interferes with macrophage function and CD4's function. That's why it increases the risk of TB. Silicotuberculosis, I'll have more risk of tuberculosis as well, right? Silicotuberculosis. And yes, silicosis, there's an increase in risk of lung cancer. That's there. It's not like your coal. It will definitely increase risk of lung cancer, and the common cancer is your adenocarcinoma, right? So these are few pointers. Please don't forget eggshell calcification could be a very important MCQ which can come in an exam, fine? Okay. The next pneumoconiosis I'm going to talk about is asbestosis. So asbestos, there are two industries which I want you to remember. One is ship manufacturing industry, not the person who work in ship, it's manufacturing of ship, and insulation. The place where they manufacture the insulation tapes, insulation tubes, everything has silica particle in it, right? Sorry, asbestos particle in it. Asbestosis, there are two questions which keeps on coming. Perfect, Daksh said the right thing. The ferruginous body is obviously the microscopic finding of asbestosis. Right, whatever Daksh said, ferruginous body. Daksh is way ahead of the time, right? So ferruginous body or the asbestos body, which is Pearls positive. It's an iron deposit. It's ferrous, right? Ferruginous. It's an iron deposit surrounding the asbestos fiber. So I call it ferruginous body, right? Or I can also use the term asbestos body. So asbestosis and cancer. This has been repeated multiple times, but in the recent past, it's not been asked. But again, if it comes in an exam, it will be useful for you. What's the most common cancer secondary to asbestosis, and what's the specific cancer secondary to asbestosis? Both is important. Most common, great, is adenocarcinoma. Good luck as well as Satish. And the specific cancer is mesothelioma. Like I said, this everyone knows. Maybe unfortunately, that is the reason that the exam authority is saying that I'm not going to ask question on this. But if it comes, it will be a very easy question, and I'm sure you will write the answer. Fine. Great. Let's go to the next question. Let's see if we can come to a diagnosis. First, let's read the question. I'm not going to show you the image. I'll show you the image after reading the question, because I always believe that image-based questions, the biggest problem is the image. Without image, I am sure most of you will try to come to the right diagnosis. So please comment on the right answer. Then definitely I'll show you the image. It's an IBQ. I'll read the question with you guys. A person with a road traffic accident 3 days after injury develops tachypnea, breathing difficulty, and collapses. So the following will be seen in the, and the image of the lung biopsy is below. What is your diagnosis? Can anyone tell the right answer? And if possible, tell me perfect, right? See, Daksh, Satish, Monica, FMGE aspirant, all of you have told the right answer even without the image. That is the only thing. Please, in the next 10 days, practice this. In an IBQ, hide the image. Hide the image and then go and look at the question. If you can solve it, don't require the image. Now let's look at the image. If you look at this image, this is a blood vessel. Okay, the entire thing is a vessel. And what are these? Anything clear in microscopy is fat, right? You'll have fat and you'll have the bone marrow also attached to it, because in a road traffic accident, the femur will get broken, and femur is a long bone. In an adult, it will be filled with fat that enters the blood circulation and becomes a fat embolism, right? Perfect is a classical case of fat embolism. You are absolutely right. Trauma to the lungs is not going to cause death, right? ARDS can cause. See, again, clinically, I have only two differential diagnoses here. One is fat embolism, the other guy is ARDS. Fine. Now, you guys are going to comment. This is for you. Fine. Tell me, what will be the microscopic finding if the patient is suffering from ARDS? If the patient is suffering from ARDS, what will be the microscopic finding? ARDS, microscopic finding. Amazing, Loka Satish. Great. So think of an hyaline membrane. Okay, there are two possibilities for ARDS. It's 3 days, right? If it's 74 hours, most likely you'll be having hyaline membrane only. But if it's a late one, you might have fibrosis. That's all. How do you identify an hyaline membrane? Hyaline in microscopy is pink. So if you have an alveoli like this, let's assume this is an alveoli, and the entire alveoli lined by a pink material, I'm going to call it a hyaline membrane, right? That's how an hyaline membrane looks. This is how an hyaline membrane looks. Again, clinical history can be the same, because hyaline membrane disease or an ARDS is again an acute pathology, which can also be secondary to road traffic accident. The only difference for me is microscopy. In this patient, I'm having fat or bone marrow space. I'm going to call it a fat embolism. The time is very important. Lung involvement is one of the major cause of death in case of a bone marrow fat embolism. The fat can get stuck in fat embolism, even the head. So you can have headache, confusion, stroke, hemiplegia, or weakness of muscles. Also can be an added symptom, not just in the lung, can block any vessel in the body. Fine. So these are the things about this question. It's a very classical PYQ. The time is important. 3 days is an important thing. There is a criteria called as GERD criteria, GURD, right? This is a GERD criteria for diagnosing your fat embolism. You must have read that in orthopedics, right? It's a combination of clinical criteria. In pathology point of view, there will be thrombocytopenia that results in the purpura and petechiae things, and you'll have loss of SPOD, and in biopsy I can see fat embolism, right? GERD's criteria. Great, Sesha, right? You're back. Now let's comment on this question. So with this question, we'll try to kind of cover most of the leukemias required for us, fine? What do you think is the right answer for this question? I hope it's visible. If not, I'll read the question. 40-year-old patient presents with weight loss, anemia, fatigue. Blood work shows WBC count of 88,000, hemoglobin of 9 gram, and there is basophilia. There's enlarged spleen and liver. Which of the following changes will be seen in the cytogenetics of the patient? Amazing. It's a very simple and classical diagnosis, right? What's the diagnosis? The classical case of CML. The very classical case of CML, the diagnosis is going to be Philadelphia chromosome, option D, translocation 922. Fine. Okay. Since we are in, like I said, in leukemia, I'll touch on the very important salient points for diagnosis of almost every leukemia required for us, and maybe the important CD markers for few lymphomas as well. Fine. Now let's have a look at it. So here, first important thing, when do you call something an acute leukemia and when do you call something as a chronic leukemia? What do you think is the bifurcation? When do you call something as acute and when do you call something as chronic? More than what? More than or equal to? Great, 20%. Fine. Blast more than or equal to 20% in bone marrow or in the blood. It's not in both. In bone marrow or the blood, I call it acute leukemia. Here, it's a mixture of blast plus mature cells. If I see both blast and mature cells, blast should not touch here. Yes, FMGE aspirant, I am doing that. Fine. Okay, you'll have result in chronic leukemia. Again, our goal is only one thing, diagnosis, and that's all is our goal. Fine. So I'm going to give you different clinical scenarios. I want you to tell what is the next step, and for every scenario, I want you to tell what is the investigation of choice. Because if you look at leukemia, this is what has been asked. Next step, investigation of choice, right? Okay. Let's say Age group, I'm just writing a random age group, a 25-year-old person. We'll keep common age group for every case scenario. What are you going to see here, right? A 25-year-old person, in the blood there is 40% blast. What is the next step? What's the next step? I'll give you options. You'll do a bone marrow examination, or you do a flow cytometry, or you will do a genetics. What's the next step? First, tell me the diagnosis. 40%, let's assume this 40% is myeloblast. I'll give you that also. It's a myeloblast. What's the next step? First diagnosis, then the next step. Daksh, myeloblast, what is AML, right? I'm sure that's a typo, fine. I'm having an AML patient, right? Perfect. So what is the next step? Diagnosis, right? First, great. Next step. Is it genetics, bone marrow, flow cytometry? Comment on it. See, maximum you will become wrong, right? It's fine, completely fine to do mistakes. The next step is flow cytometry. Please keep in mind, the next step or the investigator choice here is flow cytometry. I don't want a bone marrow examination, right? Please do remember, if I can diagnose something on a peripheral smear, FMGE aspirant, you only said with confidence that it's acute myeloid leukemia. So I don't want a bone marrow done again. If you can diagnose with peripheral smear, go with flow cytometry. That's the investigator choice, fine. Again, same age, blood, there is 15% blast. I am assuming it's myeloblast. What's the next step? Do you want to do flow cytometry, or call it chronic leukemia, or do a bone marrow examination? What's the next step here? And what is the investigator choice? Next step here, perfect. Here, the next step is bone marrow examination, right? The reason why I want a bone marrow examination here is very, very simple, because here the blast is not touching 20%. Look, Satish, I don't want to jump to calling it CML because I need to do a bone marrow, right? The criteria is either blood or bone marrow. I do a bone marrow examination, then if it is, let's assume in bone marrow examination, the blast is 45%. Can I now call it AML? Yes, I can call it AML. Then my investigator choice is undoubtedly flow cytometry. Okay, so it doesn't matter here. If in peripheral smear, if it's less than 20%, do a bone marrow examination, see the number of blasts in the bone marrow. If it is more than 20%, go for flow cytometry. I'll give you one more scenario, fine? Okay, I'm having a patient who is having suspected, okay, CLL. So when you suspect CLL or chronic lymphoid leukemias, there are 2 pointers very important for me. You will have lymphocytosis in chronic lymphoid leukemia, and then you'll have something called as smudge cell. They have smudge cell and lymphocytosis. These are 2 very important things for you to suspect CLL. What is the next step? Again, everything it is about next step and investigation of choice. Because most of the questions in the current scenario for any exam is asking what will you do next? Suspect a diagnosis, please confirm. How do you confirm? Do you need a lymph node biopsy? Do you need a bone marrow biopsy? Or you do a flow cytometry? Or you do a genetics? What's the next step? So this is the answer for any case when you suspect CLL, chronic lymphoid leukemia. For anything with chronic lymphoid leukemia, the next step again is perfect, flow cytometry. You don't want a lymph node biopsy, you don't want a bone marrow biopsy. If you see smudge cells and lymphocytosis in peripheral smear, go with flow cytometry. Confirm, that's enough, fine. Okay, next. You're suspecting CML in a patient. What do you think is the next step? When I say suspect CML in the patient, let's assume like our question, a classical patient with a splenomegaly, basophilia, everything is there. I am suspecting CML. What will it be the next? Bone marrow examination. Will you do a flow cytometry? Will you do genetics? Great, Loka Satish, right? So I'm not going to do bone marrow examination here, and I'm not going to do flow cytometry here, because flow cytometry only for chronic myeloid leukemia, there is no flow cytometry. It's not required at all. You need to do genetic diagnosis only. Of the genetic diagnosis, obviously I will prefer fish to be better than your karyotyping, right? It's fish. Here it's not flow cytometry. For every other thing, it's flow cytometry. Every other leukemia is flow cytometry except CML. In CML, I'm going to look at fish, right? I hope it's clear. I have very classical thing for all the acute leukemias and CLL. Investigation of choice is fish. That's all, fine. Now let's say any lymphoma, whatever it is, any lymphoma, fine. So how do I diagnose any lymphoma? Be it Hodgkin's, non-Hodgkin's. The first thing for me is age. If you have a lymphoma in a child, there are only two possibilities. One, it can be an ALL, acute lymphoid leukemia lymphoma. Other possibility is Burkitt's. There are only two lymphomas which can happen in a child. First, do remember that. There's no other lymphoma which can happen in a child. If it's in a young person, first possibility, think of Hodgkin's. A young person, obviously I'll think of Hodgkin's first. If it's an elderly person, then I'll think of non-Hodgkin's lymphoma, right? So age-wise, I have a classification. Age-wise, I have a diagnosis. This is how I'll think of child and young person and an elderly person, right? I hope it's clear. Fine. Okay. Now again, what we are doing is having one classical finding for any choice. For any lymphoma, investigation choice is same thing. I'm going to investigate using biopsy and your CD marker. No other thing, right? For every lymphoma, the investigator choice is biopsy and markers. That's the investigator choice for any lymphoma, fine? So tell me, what is the microscopic finding in biopsy of Burkitt's lymphoma? We'll start with the easiest one, which I am sure everyone knows here, fine? So for any lymphoma, we'll start with Burkitt's. Burkitt's lymphoma, what's the biopsy finding? Perfect. No one can forget it, right? So 𝐒𝐂𝐈𝐀 appearance is like the MBBS equivalent of powerhouse of cell and mitochondria and NEGT, right? No one will ever forget 𝐒𝐂𝐈𝐀 appearance, right? And if I have to ask one CD marker, it is CMYC. There are lots and lots of CD markers, but don't forget this one. It is your CMYC. CMYC is a classical finding for Burkitt's lymphoma, fine? Okay. Then here, follicular lymphoma. Follicular lymphoma, microscopic finding, it's follicles, right? There will be multiple follicles in microscopy. Okay, that's a very classical finding in follicular lymphoma. Translocation 14-18. This has been asked before in follicular lymphoma. In the 18th chromosome, that's the IHC as well, BCL2. So if I have to go with only one IHC for follicular lymphoma, I will go with BCL2. Fine. Next, for mantle cell lymphoma. Mantle cell lymphoma especially doesn't have any classical light microscopic finding, right? There's one IHC or one marker or one gene which I want to remember in mantle cell lymphoma, which is cyclin D1. If a tumor is cyclin D1 positive, if it's a hematological tumor, it has to be a mantle cell lymphoma, undoubtedly, fine? Now let's go to your Hodgkin's. What's the diagnostic cell in Hodgkin's called as? We have one classical diagnostic cell. No one can forget that, right? We have a classical RS cell. RS cell is diagnostic of Hodgkin's lymphoma. So when I say Hodgkin's lymphoma, I divide the Hodgkin's lymphoma into classical Hodgkin's lymphoma, and we have something called an NLPHL. NLPHL stands for that it's a non-classical variant or nodular lymphocyte predominant Hodgkin's lymphoma. For a classical Hodgkin's lymphoma, you have the classical outside appearance and everything. In NLPHL is where you must have definitely heard them, right? You have popcorn shaped RS cell, a popcorn cell. It's a very classical finding. For a classical Hodgkin's lymphoma, there are multiple subtypes of classical Hodgkin's. Every classical Hodgkin's RS cell, the marker is same. They are 15 or 30 positive. Okay, they are CD15 or CD30 positive, and NLPHL RS cells are actually CD15 and CD30 negative. That's very, very important, and they are positive for CD20, CD45. Please do remember this. Don't forget this. In Hodgkin's, the IHC depends on the type of Hodgkin's. Read the question carefully. If it is NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma, 1530 negative, popcorn variant of RSL, 2045 positive. And classical Hodgkin's, the outside nucleus, 1530 positive, rest of them are negative, fine? So this is about brief overview of lymphomas and leukemias. We know about leukemias, when to suspect something, when to diagnose something, how to confirm. We know about lymphomas, Hodgkin's, non-Hodgkin's, few classical non-Hodgkin's lymphoma we saw, age we saw, and how to diagnose we saw, fine? Let's go to the next question. Okay, what's the right answer? It's a very simple one. We did see a little bit about hypersensitive reactions already, right? Answer? a very simple one. Great, amazing. See, this is a trap. Most of the student, if you're attempting an MCQ for the first time, you will jump and say, okay, it's dermatitis, hypersensitivity, type 1. It's not type 1. It's never type 1. Anything contact dermatitis goes into type 4. This is a trap. You might end up in going up with the wrong answer, right? Contact dermatitis is not a type 1 hypersensitivity. It's type 4 hypersensitivity. Here the question is about poison ivy. It's fine. Nickel, any contact dermatitis. The metal nickel can also cause contact dermatitis. Any contact dermatitis will be type 4 hypersensitivity. Again, at the same moment, I want you to remember this also. Celiac disease, okay, Hashimoto's thyroiditis, your type 1 diabetes mellitus, your rheumatoid arthritis, and I'll tell you why I am grouping these things here. Right? If I tell celiac disease, what is the first thing which comes to your mind? What antibody comes to your mind? What antibody comes to your mind? Celiac disease? Your anti-TTG antibody? That definitely comes to your mind? Yes, which it comes to your mind, right? When you think of Hashimoto's, anti-thyroid peroxidase antibody, yes? Type 1 diabetes, again there's an antibody called an anti-GAD antibody, yes? Rheumatoid arthritis, rheumatoid factor and anti-CCP. So whenever you remember any of this disease, what comes to your mind is the antibody. So if antibody comes to your mind, what type of hypersensitivity do you think these are? If antibody is the first thing which comes to your mind, what do you think will be the type of hypersensitivity here? Type 2 or type 4? Type? Great. So the answer is type 4. Okay, that's why I said it's a trap. Right? So contact dermatitis is a dermatitis which will be type 4 hypersensitivity, and all these are type 4 hypersensitivity. But yes, you do see antibodies. I'll tell you why. Fine? I'll tell you how these antibodies are formed, and we'll definitely never forget it's type 4 and not type 2. Fine? Let's take an example of celiac disease. All of you know the pathogens of celiac disease, right? So what happens in celiac is, it's otherwise called as a gluten sensitive enteropathy, right? So what happens is, a sensitive person consumes the gluten. Gluten will be converted to a substance called as gliadin, and this conversion is the help of TTG enzyme, tissue transglutaminase. So this gliadin will elicit the immune response. Again, not in every person, only in sensitive individual. So this immune response will attract your, avoid bro foods, is perfectly right, will attract your CD4 T cells. So this CD4 T cells will destroy enterocytes, or will destroy the intestinal cells or enterocytes. Right? Okay, this is the pathogenesis. Now tell me, what is causing the damage? Anti-TTG is causing the damage, or CD4 T cells is causing the damage? CD4 T cells is causing the damage. Type 2 or type 4? Type 4. Because T cell mediated. Anything cell mediated is type 4 hypersensitivity, right? Now tell me, how do you think my body will respond to this disease? Should it try to stop the disease? Yes. The only way to stop the disease is, if I stop this enzyme, can I stop conversion of gluten to gliadin? If I stop conversion of gluten to gliadin, will the disease happen? It won't happen, right? It's a body's response. So what my body does is, because I'm having a damage, my body produces anti-TTG. Now you tell me, the anti-TTG here is the cause of the disease or effect of the disease? Is the cause or the effect? It's the effect. I use it for diagnosis. I am not denying that anti-TTG will be present, but it's not the cause of the disease. It's the effect of the disease. Same with your Hashimoto's. Same with your type 1 diabetes. Same with your rheumatoid arthritis. All these are T cell mediated problem where I have an effect of antibody production, that I use it for diagnosis. I am not denying that fact, but all these four are type 4 hypersensitive reaction and not type 2 hypersensitive reaction. I hope you will never ever make a mistake again. Just because I have an antibody production, don't jump into type 2 hypersensitivity. It's type 4. All these are classical type 4 hypersensitive reaction, right? I hope everyone knows the concept here now. Fine? Okay, great, amazing. So next, one more question. I'm sure you know the answer. So all these are PYQs, right? You are experts in PYQs. What's the right answer? The gene involved in hereditary hemochromatosis. Great. Anyone else apart from Shesha? What's the gene involved in hereditary hemochromatosis? HFE gene. Okay. So hereditary hemochromatosis, first of all, is an autosomal recessive inheritance. Okay, great. I have two types of hereditary hemochromatosis. One is an adult hereditary hemochromatosis. That's where the most common gene involves HFE gene. There are lots of genes involved. Ferritin can also be involved. There are multiple genes which can be involved, right? And I also do have childhood or juvenile hemochromatosis. Right? In a juvenile hemochromatosis, the gene involved is HJV gene, hemojuvelin gene, right? So again, based on the age group, the gene might change. If it's a scenario-based question, please look at the age group. It's a 5-year-old having hemochromatosis, think of HJV. The 30-year-old having hemochromatosis, think of HFE gene. Again, that's important for you to understand that, right? So what happens in whatever may be the cause, transferrin can be a problem in hemochromatosis. Actually, in adult hemochromatosis, there are 8 different types. The only type which you remember is HFE mutation, right? Whatever may be the cause, what will happen is the important problem in hemochromatosis is your hepcidin. Hepcidin will be not functioning. It will not be functioning, maybe due to the structural absence or some of the compounds absence. It will not function. If hepcidin is not functioning, there will be overactivation of your ferroportin. What do you think ferroportin does? As the name says, it ports iron. So there will be excess movement of iron from the duodenum into the serum. So normally you'll have all the iron in the duodenum. Now it goes to the serum because of overactivation of ferroportin. So this results in excess serum iron, which results in your disease hemochromatosis. Fine. What is the difference between hemochromatosis and I'll give you one more thing, hemosiderosis? What is the difference? Hemochromatosis versus hemosiderosis. What do you think is the difference? Siderosis. Hemosiderosis is also an iron overload. There is also iron overload only. But the only difference between hemochromatosis and hemosiderosis is a secondary or an acquired iron overload. When you have a patient with thalassemia, treatment of thalassemia is chronic blood transfusion, right? So when I keep on giving blood transfusion, it will result in secondary iron overload. In hemochromatosis, is a primary problem. Whatever may be this, hemochromatosis or hemosiderosis, I need an investigation of choice. Okay. Theoretically speaking, I have one gold standard investigation, which is dry weight of iron of the liver. I'll write it here, but it's never ever done in the life, right? It's dry weight of iron in liver cells. Okay, this is like gold standard method. Gold standard way for preparing for any competitive exam is read through all 6 years of MBBS. That doesn't happen, right? So that's gold standard. It's only for textbook. It's not for real life. So for real life, I cannot use or measure the dry weight of iron in the liver cells, hepatocytes, right? So for real life, what I'm going to go for is only one important investigation, which is transferrin saturation. Please do remember this. In any patient in your MCQs, if transferrin saturation is more than 45, the normal is around 36 to 37. If it goes more than 45, think of iron overload. Because in no other normal condition, transferrin saturation will never be high. The only condition where saturation will be high is hemochromatosis or hemosiderosis. Can you comment what is the diagnosis? Sorry, what's the treatment? I am sure you know the treatment. What is the treatment? A very simple treatment. Your iron chelators, right? You have something called an iron chelators. That's a treatment for hemochromatosis or hemosiderosis. Your desferoxamine or deferricerox. These are iron chelators which can be given, right? Treatment is simple. I have few iron chelating agents. I am sure Dr. Ankit must have talked about iron chelators. That's how you treat your desferoxamine or deferricerox. Perfect, right? That's how you treat your hemochromatosis or siderosis, right? Okay, go to the diagnosis. Again, it's a very simple diagnosis. I know you will jump to the answer. You guys are good. The only problem is you don't believe that you are good. FMGE aspirant has gone to Buerger's disease. I purposefully have put 2 options, B and C. Okay, I'll ask you one honest question. Please answer yes or no. Tell me how many of you saw this Buerger's disease and then ticked it and didn't read option 3 and option 4. How many of you did that? Honestly, tell me how many of you did that. You saw the history, you know it is thromboangiitis obliterans, you looked for Buerger's disease and you skipped option 3 and option 4. If you have done that, please don't do that in the real exam. Right? Because it's just 4 options, right? 10 seconds, 5 seconds extra. Right? Don't do that. There is a possibility if you know, see, let's in this question there's no problem. Let's say this option 1, it looks like right, you read that and leave it, and the last option is all of the above, you lose it, right? Silly mistakes. In any exam, silly mistakes will be easily like 5 to 10 questions. In 300 questions, 5 to 10 of them. If you have written the FMGE exam previously, tell me honestly, or any GTs, tell me honestly, when you review a GT, at least 5 to 10 questions you must have known the answer but still made a mistake because you didn't read all except, or like this, all 4 options. How many of you have done that? If you've done that, put up your hands. I have done that during my exam time. I'll tell you a way to not get tempted, Shisha. You must have done that, right? If that is true, that's a difference between 140 and 150. It's just 140 to 150. It's extra 6 months, right? I'm not asking you to learn more. It's not about learning more. It's about delivering what you've learned. You guys are good, like I said. You just have to be focused, concentrated. Use this rule. For the first 10 seconds in any exam, don't write the answer. By default, don't write the answer. 10 seconds, if you want, put your clock there. Let it 10 seconds reduce. Till that, see the question. In 10 seconds, I am sure 100% of you will read the question twice. So wait for 10 seconds, right? Just 10 seconds, even if you know the answer, don't write the question. After 10 seconds, right? So all these silly mistakes will reduce. From 10 MCQs, if it becomes to 2 MCQs, you have 8 extra marks, right? Just do that, right? Your answer is right. It's TAO or Buerger's disease. Smoker is the etiology. Intermittent leg pain. Claudication is classical. Buerger's is a small and medium vessel vasculitis. It's one thing which can affect both small and medium vessel. And Buerger's disease, treatment, you know, treatment is quitting smoking, which never happens, right? Buerger's disease is the only vasculitis which will involve nerves. There's a question which came once. It involves arteries, it involves veins, and it involves nerves. Please do remember them. It's the only vasculitis which involves nerves. FMG aspirant, just to answer your comment, after 10 seconds, tell me honestly, let's talk heart to heart, fine? If you cannot identify an answer in 10 seconds, do you know the answer or you make a guess? You make a guess. That's all. As simple as that. So it's very simple. You will know the answer in 10 seconds. If you don't know the answer in 10 seconds, you will never know for life. Not just here, throughout your medical career. You know the diagnosis instantaneously. You might call it fluke. It's not fluke. It's the 6 years of your MBBS life which is there in your brain. Your brain knows the answer. You are not trusting your brain. That's all, right? It's simple. 10 seconds, you know the answer. Write it. After 10 seconds, you're not getting the answer, which means you don't know the answer. Skip and go to the next question. As simple as that, right? Okay. The name of this is TAO. This is a microscopic finding. There is thrombus. The entire blood vessel is completely occluded here. That's why I call it thromboangiitis obliterans, right? TAO, thromboangiitis obliterans, or the Buerger's disease, right? Okay. Okay. Answer? Something we just now saw. Tell me the right answer. It's a very simple question. A 25-year-old person with malabsorption diarrhea after consuming oats. We just now saw that someone also commented bro foods, right? Bro stands for barley, rye, oats and wheat, right? So bro foods is classical case of a celiac disease. So celiac disease, you're going to have your GTG antibody. There are 3 more options. Where do you see double stranded DNA? Which condition you see double stranded DNA? You see them in SLE, right? Where do you see anti-Jo1? Anti-Jo1 you see in? Great, you see in? There's a condition called as a Myositis. Great. Where do you see SSA? Where do you see SSA? SS stands for Sjogren syndrome. It's not difficult to remember. SS stands for Sjogren syndrome. Okay? It's SSA and SSB, right? Sjogren syndrome A and Sjogren syndrome B. Dermatomyositis and double-stranded DNA for SLE. Fine? Perfect. Great. Again, we'll ignore the image. I'll go to the image later. Tell me the answer, whatever comes to your mind. A young male with a testicular lesion underwent a high inguinal orchidectomy. Histology is shown as below. The tumor cells are positive for 𝐒𝐂𝐈𝐀. What is your diagnosis? There's no image here, but still I am 100% sure you can diagnose with an image, right? Quite a few of you said seminoma, right? Now first question, teratoma, is it common in men? Not that common in women. Yes, I think of teratoma. Okay. Choriocarcinoma, it happens post-pregnancy. It's not common in men at all. It's very, very rare in testes, right? Because I need placenta for choriocarcinoma, right? Embryonal carcinoma, yes, possible in men, but embryonal carcinoma is not positive for 𝐒𝐿3/4. And embryonal carcinoma microscopy is a microscopic finding. We have nests of tumor cells with septa, and the septa has lymphocytes. There's a classical finding, nests of tumor cells with lymphocytes in septa, which is diagnostic of seminoma, like you guys said, right? Just few pointers to seminoma. What's the counterpart of seminoma in women? We call them dysgerminoma, right? So seminoma and dysgerminoma, they are the most common germ cell malignancy. It's malignant tumor. It's the most common germ cell malignancy in women and in men. Seminomas, I told you the microscopic finding. IHC, there are few things which are important in seminoma. This has been asked multiple times. PLAP is positive. PLAP is a very old marker. To be honest, I don't have PLAP in my hospital. It's maybe 30 years back, PLAP was huge. But now PLAP is long gone. CD117, this is positive. This might be done. But 𝐻3/4, NANOG and SAL4. Do remember them because these are classical markers for seminoma. 𝐒𝐄𝐈 is just a few previous year questions I am talking about. This is just to final brush up for you to have random topics here and there. Fine. Monica, right? The LDH is a tumor marker. I don't do LDH as in microscopy. It's done in the blood as a tumor marker. You're right in saying that. But whatever we see, PLAP, CD117, 𝐻3/4 NANA, or immunohistochemistry done on a biopsy. Fine. Okay. Diagnosis. Sorry, answer. What's the answer? Simple one. Fragile X syndrome is an X-linked recessive inheritance. It's not an X-linked dominant inheritance. I know for a fact that Wikipedia says X-linked dominant, but Harrison as well as Robbins says X-linked recessive, so I'm going with X-linked recessive. Fine. See, because Fragile X has multiple diseases, genetics have multiple inheritance, so I'm going to go with standard books. Standard books say X-linked recessive. If it's both X-linked recessive and X-linked dominant as the option, I would prefer this. Fine. Because the common variation is X-linked recessive, so I go for X-linked recessive. Fine. Okay. Next. Okay. Answer. It's a very simple question. Read the question carefully and tell the answer. Which of the following is involved in leukocytes adhesion? I hope okay. Hope before my net goes again for a toss. What's the diagnosis here? What's the right answer here? Which of the following organism causes or is the etiology for condyloma acuminata? Condyloma acuminata is an HPV related problem, right? There are two variants of HPV, HPV 6 and 11. Both HPV 6 and 11 increase the risk of the genital warts, which is condyloma acuminata. What's the malignant phenotypes of HPV? So malignant phenotypes of HPV is here, HPV 16 and HPV 18. HPV 16 and HPV 18 can result or is the risk factor for your cervical cancer, right? Shisha, the previous question was then image of an granuloma. The inflammatory cell which is seen in granuloma is nothing but your activated macrophages or the epithelioid cells. Even the giant cells are an accumulation of epithelioid macrophages. Fine. Okay. The last one, I'll wind up with this. Which of the following is the most common renal calculi? Because generally we don't see microscopic renal calculi. Look, Satish, I would say primarily no. Yeah, some of the MCQs can come because in your university exam you have 10 questions as MCQs. It might help you, right? Calcium oxalate crystal is definitely a common cause of most common type of renal calculi, right? So in renal calculi, there are urine microscopic findings for renal calculi, right? Like calcium oxalate. What is the crystal shape? Can anyone tell me the crystal shape for calcium oxalate? You have something called an envelope shaped crystals. Looks like an envelope or envelope, whatever you want to call. Stu-White calculi has something called a coffin lid. It looks like a coffin lid. Then coffin lid crystals you will see in urine microscopy, right? How does the coffin look like? If you've seen Undertaker, that's the only place I've seen coffin, right? That's a coffin lid calculi, fine? It looks like a coffin lid. That's a Stu-White stone or the triple phosphate stone, and this is your envelope shaped crystals, which is seen your calcium oxalate crystals, right? A coffin lid crystal and an envelope shaped crystal. And your Stu-White stones is one important history for Stu-White stones which might be helpful in diagnosis: UTI. It's especially seen in proteus organism, but anything which predisposes infection, predisposes or increases the risk of Stu-White calculi. That should be then the history for you to take a clue. Okay, it's Stu-White stones, fine. And this is hexagonal shaped crystals. Hexagonal shaped crystals are seen in cystine calculi. Cystinuria is the only place where you see cystine calculi, and if you have a crystal like this in urine microscopy, think of cystine stones as a history, right? And here, this is rhomboid shape. Rhomboid shaped crystals are diagnostically classically seen in uric acid stones. Okay? Again, the utility of this in real life is very less except for cystine stones. Because when you see a cystine calculi, it's very hard to break. So you directly go for a surgical removal and you don't use the ultrasound to break the stones. You don't do a lithotripsy with a cystine calculi, you do a surgery. That's the only utility of the microscopy of urine examination in diagnosis of urine calculi. Otherwise, kidney stones or anywhere in the urine tract, stones are diagnosed in clinical examination. The ureteric colic, and you treat the patient. That's how it is, fine. Okay, that's all regarding today's discussion. Sorry for the glitch in the internet. The favorite thing, and hopefully if there are any other queries, do let me know. Ping me on Instagram or Telegram. I'll be more than happy to reply to questions. I'll be more comfortable in Instagram, or in my Insta page there's a WhatsApp number also. You can come and connect with me in the WhatsApp as well. All the very best for your upcoming FMGE exam. I am 100% sure you will do well. So just be confident, and I'm sure you will do well, right? Rock your exam and see you on the other side. Hopefully in future I'll maybe we will both will diagnose some case together and you will treat it, fine. Thank you. All the very best. Bye bye.